I'm Dr. Dharmandra from SGPJ. The topic of today's discussion is I want to discuss spectrum of kidney disease in patient on diabetes, in a patient of diabetes mellitus. As you know, diabetic nephropathy not the sole cause of renal dysfunction in patient of diabetes. Rather than apart from diabetes nephropathy, there may be so many causes of renal dysfunction in this group of patient. Coming to the problem statement related to diabetes with renal failure, the crude prevalence rate in urban areas of India is thought to be around 9%. In rural areas, the prevalence is approximately 3% of total population. With the population of more than 1,000 million, the estimate of actual number of diabetic in India is 14 million, and that's why it is also known as diabetic capital of the world. Leading cause of end-stage renal disease, and it's affect around 40% of type 1 and type 2 diabetics. How we diagnose this diabetic nephropathy in a patient who is diabetic with renal dysfunction? Actually, it is diabetic nephropathy is a clinical renal syndrome, which is, though the term is histopathological, but most of the time it is diagnosed by clinical means. It is a secondary glomerular disease in a patient of diabetes, which is indicated by presence of microalbuminuria, that is albumin excretion more than 300 milligram per day or 20 microgram per minute, after exclusion of other renal disease in a patient of renal dysfunction and diabetes. Though, as I have already told, the term of diabetic nephropathy is histopathological, but diagnosis is always a clinical one. So, persistent proteinuria more than 300 milligram per day or 200 microgram per minute is in absence of urinary tract infection with 2 additional first void sample specimen collected during the next 3 to 6 months is clinical hallmark of diabetic nephropathy. We need some additional criteria for this diagnosis. Number 1 is the presence of diabetic retinopathy and absence of clinical or laboratory evidence of other kidney or renal tract disease. This clinical definition of diabetic nephropathy is valid in both type 1 and type 2 diabetes. So, coming to the screening part of diabetic nephropathy, these patients should be screened annually. In type 2 diabetes, it should be started from the diagnosis. At the time of diagnosis, while in a patient of type 1, patient 1 should screen 5 years after the diagnosis of type 1 diabetes. The screening should include measurement of urinary albumin creatinine ratio in a spot urine sample, measurement of serum creatinine, and estimation of GFR by MDRD or other formulas. Coming to the progression of diabetic kidney disease, once there is development of albuminuria or overt nephropathy, the decline of GFR ranges with from 2 to 20 ml per minute per year, which is highly variable, and even in some patients the fall in GFR is more than this, and it may be in the tune of around 40 ml per minute per year. So this is the natural history of diabetic nephropathy in a patient who is suffering from diabetes. As you can say, the clinical albumin excretion, clinical albuminuria is started usually after 2 to 3 years between after the diagnosis of diabetes, or around 5 years after the diagnosis of diabetes, and it peak after 10 to 15 years. And as you can see, the yellow line which is showing decline in GFR, and you can see by yellow line the GFR declined to almost 30 ml per year after the 10 to 15 years after the onset of albuminuria. So, coming to today's topic, non-diabetic kidney disease. First of all, I will talk about non-diabetic kidney disease, how we should suspect non-diabetic kidney disease in a patient of diabetes who presented to you with renal dysfunction. First of all, I will give you the theoretical aspect, then I will give you some case series related to non-diabetic kidney disease in a patient of diabetes, and then I will give you the data of my institute in patient of type 2 or type 1 diabetes suffering from non-diabetic kidney disease. So coming to the non-diabetic kidney disease, non-diabetic nephropathy complicate type 1 diabetes is a rare phenomenon in type 1, but in type 2 diabetic it can may be seen in the tune of sometime 25 to 30% of Asian population and 22% of European population. It's not a unfrequent finding in a patient of type 2 diabetes. So non-diabetic renal disease superimposed on diabetic nephropathy occur more frequently in type 2 rather than type 1 diabetes. So once you have suspected non-diabetic kidney disease, the spectrum in these patients could be, a patient may be of patient of glomerular disease, sometimes glomerular disease superimposed on diabetic nephropathy in background. Patient may have tubulointerstitial nephritis, or sometimes acute tubulointerstitial nephritis superimposed on diabetic nephropathy. Patient sometimes may have chronic tubulointerstitial nephritis or urinary tract infection or renal parenchymal infection, papillary necrosis, and sometimes vascular disease like renal arteries, atherosclerotic renal artery disease, or sometimes atheromembolic renal diseases. After how we should pick up these patients, how we should reach the diagnosis of non-diabetic kidney disease in a patient of diabetes. So the proposed marker for non-diabetic kidney disease in diabetics are: number 1 is short duration of diabetes and onset of renal dysfunction. Number 2 is no evidence of diabetic retinopathy in fundus. Heavy proteinuria or decline in GFR which is inconsistent with the natural course of diabetic nephropathy. Hematuria, acute deterioration in GFR or subacute decline in renal GFR or rapidly progressive renal GFR. These are the proposed markers for non-diabetic kidney disease in these patients. So, but none of these proposed markers has either absolute sensitivity or 100% specificity for non-diabetic kidney disease. Nevertheless, the marker used in combination may sometimes useful and may guide you for kidney biopsy. Diabetic subject that may benefit from kidney biopsy should be identified by case. Once you have done kidney biopsy in this patient, the spectrum on histopathological examination may be solely diabetic nephropathy. Even you have suspected non-diabetic kidney disease, sometimes non-diabetic kidney disease on the background of diabetic nephropathy. Sometimes patient may have pure non-diabetic nephropathy, or even you can find normal renal structure. So coming to the case presentation, my first case is a typical patient in which we thought of non-diabetic kidney disease, but ultimately after kidney biopsy, the biopsy was suggestive of diabetic nephropathy. So it is a 44-year-old male who is diabetic since last 6 years on oral hypoglycemic agents. Glycemic control was poor. He has creatinine of 1.6 4 months prior to this admission. He is also hypertensive and on calcium channel blocker like amlodipine. He presented to us with decreased appetite and nausea for 2 months, breathlessness for 2 months, and pedal edema for 2 months. There was no history of any suggestive of systemic illness, any kind of infection, and any kind of allergy, and hematuria, and accelerated hypertension. On examination, patient has pallor, edema, and blood pressure in the tune of 130 by 80 mm of mercury. Systemic examination is unremarkable except he has few bilateral basal fine crabs, and fundus examination was done which is suggestive of proliferative diabetic retinopathy. So this is a patient of diabetes who has renal dysfunction and found to have proliferative diabetic retinopathy. On examination, he has mild anemia with the creatinine which is rising from 1.6 to 5.4 over the 7 months, but On urine examination, patient has 4 plus proteinuria and some RBCs. 24-hour protein quantification, patient is in range of nephrotic proteinuria, which is 5.2 gram per day. So to summarize, he is a type 2 diabetes who has proliferative diabetic retinopathy, but rapidly worsening glomerular filtration rate and some active urinary sediment. So we thought of two diseases: either this is a rapid progression of diabetic nephropathy or some non-diabetic kidney disease, either in form of rapidly proliferative glomerulonephritis or acute interstitial nephritis. So we planned for kidney biopsy as there was suspicion of non-diabetic kidney disease, but surprisingly this patient has found to have typical changes of diabetic nephropathy in the form of segmental to global diffuse nodular glomerular sclerosis and mesangial proliferation, nodule formation and thickening of glomerular basement membrane. You can see by arrow I'm depicting nodule formation in glomerulus, which is hallmark of diabetic nephropathy. So on biopsy, ultimately the diagnosis was nodular and diffuse diabetic nephropathy. This is the typical patient in which we thought of non-diabetic kidney disease, but ultimately on kidney biopsy that diagnosis was nothing else than diabetic nephropathy. So final diagnosis of type 2 diabetes mellitus with proliferative diabetic retinopathy, dialysis dependent advanced renal failure and diabetic nephropathy was capped, and patient was started on chronic ambulatory peritoneal dialysis as a form of renal replacement therapy. Coming to my next case, this is a 48-year-old female who is diabetic since last 10 years. She was on OHA with fair glycemic control. She was hypertensive since last 5 years and on amlodipine, but she has history of pain in large and small joint of both upper limb and 6 years. This joint pain is inflammatory in nature and she used to take NSAID frequently. She also has a history of fall of hair, oral ulcer, skin rash and with photosensitivity since last 5 years. She also has pedal edema since last 2 months and decreased appetite for 2 months. On evaluation, she has detected to have deranged renal function and she was referred to SGPGI in my institute. And there was no history of any fever, lower urinary tract symptom, and any sign symptoms suggestive of lower respiratory tract infection, hematuria, and seizures. On examination, she has pallor, edema, oral ulceration, malar rash, which is in favor of systemic lupus erythematosus. On systemic examination, patient is totally unremarkable. On fundus, she has non-proliferative diabetic retinopathy. On evaluation, she found to have anemia. She has mild renal failure. She has ANA positive with active urinary sediment. Protein is 4 plus and RBC 8 to 10 per hyperbar field. She has 6.3 gram proteinuria per day. So to summarize, a patient is a type 2 diabetic with non-proliferative diabetic retinopathy with nephrotic syndrome and clinical features suggestive of lupus. So diagnosis of lupus nephritis was capped, and patient was planned for biopsy as histopathological class is important to initiate the treatment and also for prognostication purpose. So patient was on biopsy. Patient found to have diffuse thickening of glomerular basement membrane suggestive of class 5 lupus. So after the biopsy, membranous glomerulonephritis, lupus nephritis class 5 was capped, and patient was started on cyclophosphamide and prednisolone based therapy. At present, patient is in remission. Coming to my next case, she is a 58-year-old female who presented to us anorexia, nausea and vomiting for 2 months, decreased urine output for 7 days. On evaluation, patient found to have diabetes with anemia, advanced renal failure, and she was referred to us for evaluation. There was no history of edematous illness and not suggestive of any peripheral neuropathy. On examination in our center, patient has marked pallor systemic examination was unremarkable, and fundus has no diabetic retinopathy, which make us compelled to diagnosis of non-diabetic kidney disease. On evaluation, patient is severely anemic, advanced renal failure. She has mild elevation of uric acid and mild disturbances in albumin globulin ratio. On urine routine, patient has only trace proteinuria, but on 24-hour protein, patient has 1 gram proteinuria. Here there are some clinching point. There is dissociation between urine routine and 24-hour urinary protein. While patient has severe anemia out of proportion to renal failure and hyperuricemia and mildly altered albumin globulin ratio. So to summarize, in newly detected type 2 diabetes with no diabetic retinopathy, unexplained renal failure or severe anemia disproportionate to renal failure. So we kept the possibility of some tubulointerstitial disease, as there was trace proteinuria, which is not in favor of glomerular disease. So because patient was in 5th decade and has severe anemia, so we planned for bone marrow examination to rule out multiple myeloma or any plasma cell dyscrasia. And on bone marrow examination, she found to have atypical plasma cell of around 30 to 50%. Skeletal survey was done. There was no any osteolytic lesion. Electrophoresis was suggestive of M band in gamma region, and serum immunofixation was done, in which M band was found in IgG region. Renal biopsy was planned to rule out multiple myeloma associated with cast nephropathy. So this is a histopathological diagram in which the lower arrow is showing nodule formation in glomerulus, while upper arrow is showing cast formation in tubule. The cast is typical of cast nephropathy, which is fractured cast. So final diagnosis of multiple myeloma, cast nephropathy along with coexistent diabetic nephropathy was capped. So this is a typical example of non-diabetic kidney disease in the form of myeloma cast nephropathy superimposed on diabetic nephropathy. So we started patient on thalidomide and dexamethasone regime. We also started 4 sessions of plasmapheresis in the view of myeloma cast nephropathy. Patient became dialysis independent and she was discharged on creatinine of 4 mg per deciliter. However, later the patient lost to follow-up. Coming to my next case, he's a 50-year-old male. He's a 50-year-old male who is diabetic since last 4 years, and presently he is on oral anti-diabetic agent. Presented to us severe pain abdomen with skin rash over both upper and lower limb for 15 days, decreased urine output with edematous illness for 10 days. On examination, patient has edema, blood pressure is on higher side. Patient has palpable purpuric rash over bilateral lower limb and upper limb, and fundus was done, which is absolutely normal. On examination, patient has advanced renal failure, creatinine is 7.4. Patient serology, viral serology like hepatitis B, C and HIV is negative. Patient also has ANA and ANCA negative, but on urine routine, patient has active urinary sediment with nephrotic range proteinuria. Ultrasound was suggestive of normal size kidney. So to summarize, is a patient who is diabetic but no diabetic retinopathy, history of pain abdomen, rapidly progressive renal failure, palpable purpura in both upper and lower limb, normal complement, and ANA ANCA both negative. So we clinically we kept the possibility of type 2 diabetes with non-diabetic kidney disease in the form of henoxolin purpura. We did a skin biopsy of these palpable purpura, and there is mild perivascular inflammation in dermis, and real biopsy was done for confirm the diagnosis. And here you can say focal proliferative glomerulonephritis on the kidney biopsy, and on immunofluorescence there is IgA deposition in the intensity of 2+. So the possibility of IgA nephropathy was capped. But as patient also has extrarenal manifestation like palpable purpura, abdominal pain, which was improved after the steroid start. the ultimate possibility of henoxal in purpura was capped. Patient was managed with 3 sessions of hemodialysis. It started on oral prednisolone. Patient improved. At present, patient is creatinine is in 1.2 on follow-up, and his urinary routine microscopy was only showing trace proteinuria. So coming to my next case, this is a 14-year-old girl who is diabetic since type 1 diabetic since last 10 years, presented to us generalized edema and decrease in urine output 15 days. There was no history of cola-colored urine, rash and arthralgia. On examination, patient has slightly hypertensive, pallor is there, edema is there. She has ascites, and but fundus was suggestive of no diabetic retinopathy. So on evaluation, patient is anemic, mild renal failure. She is hypoalbuminemic. C3, C4 is normal. Her urine was showing active urinary sediment with heavy nephrotic range proteinuria. Ultrasound was suggestive of normal sized kidney. So we kept the possibility of because of nephrotic presentation in a 10-year-old girl. We kept the possibility of membranoproliferative glomerulonephritis. Hence we planned for kidney biopsy. The kidney biopsy is suggestive of diffuse proliferative glomerulonephritis. You can see in a glomerulus as depicted by the red arrow, you can see there is increase in the number of resident cell in mesenterium, suggestive of diffuse proliferative GN. On immunofluorescence, the intense C1q deposition. The intense C1q deposition in the absence of features suggestive of lupus is usually diagnosed as C1q nephropathy. So final diagnosis we kept a patient of type 1 diabetes with nephrotic presentation due to C1q nephropathy with a morphological diagnosis of diffuse proliferative glomerulonephritis. We managed patient with diuretic, antihypertensive like ACE inhibitor and ARBs. Patient went into remission. At present, patient is creatinine is 1.2 and proteinuria after 6 months is only 2+. So coming to my next case, this patient is 55-year-old male who is type 2 diabetes for 8 years and was on OHA, but glycemia was not well controlled. He presented to us with fever 20 days back, history of multiple boils in lower limb for 20 days, decreased urine output for 5 days. Patient was evaluated and found to have advanced renal failure, and patient was referred for further management here. Here you can see a scar mark of multiple boil in a patient who is diabetic. On examination, patient has 120/76 blood pressure. He has pallor, pedal edema, bilateral caps on the chest, and left lower limb boils or cellulitis. On examination, patient was mildly anemic. Patient has active urinary sediment. His C3 and complement like C3 and C4 is very low, and patient 24-hour protein quantification in 1.69 gram. Fundus was normal. So again, a possibility of non-diabetic kidney disease was capped because patient didn't have retinopathy, and patient have active urinary sediment with low complement. We did biopsy as we kept the possibility of non-diabetic kidney disease in the form of RP, rapidly progressive glomerulonephritis, either because of post-infectious glomerulonephritis or because of membranoproliferative glomerulonephritis. So on biopsy, patient found to have lobular accentuation of 9 all glomeruli, which you can see as these are depicted by red arrow. The rest of glomeruli show lobular accentuation and endocapillary proliferation. IF was suggestive of positive for immune deposits. His urine output started improving, and patient become dialysis independent after steroid treatment. At present, patient is passing good amount of urine and is creatinine on follow-up of 1.02. My next case is a patient of diabetes who presented to us, who is on AHA and on poor glycemia. Patient is referred to us with history of bilateral renal calculus disease and with history of fever. She was managed outside with aminoglycoside injection, and patient was told to have tumor at left leg fossa and referred here for further evaluation. Here you can see a mass in left leg fossa, and patient has blood pressure on lower side. His pulse rate is 90 per minute. She was looking severely dehydrated and she has pallor. There was no any icterus, cyanosis clubbing. Left flank was full tender with overlying ulceration. On evaluation, patient found to have severe anemia, very high count of 28,000. She was having creatinine of around 2.8 with urine output in the range of 500 ml per minute. CT scan was done. Here you can say foci of air in the renal parenchyma. Upper arrow was showing foci of airs, while lower panel diagram showing bust of abscess into the parietes. So the possibility of emphysematous pyelonephritis was capped, and one session of dialysis was given because of metabolic acidosis. The left percutaneous drain insertion was done, and this drain was suggestive of sent for culture, which was suggestive of Klebsiella pneumoniae, which was sensitive to ciprofloxacin and piperacillin tazobactam. Antibiotics were changed as per culture. Patient improved and was discharged back to with dialysis independent state. So these are the few cases and case series in a patient of diabetes with renal dysfunction and patient having diagnosis other than diabetic nephropathy. Coming to my last part of this talk, I will present data of my institute and some review of literature. Around 3,025 patients of diabetes with renal dysfunction were admitted over the period of last 10 years for evaluation of the cause of renal dysfunction. Out of these around 3,000 patients, we did biopsy only in 135% patient, which is around 4.3%, because we could not diagnose their disease, the cause of kidney disease, by non-invasive means. So we planned for kidney biopsy. So this is the baseline demographic. You can see around 60% patients were hypertensive, or only 1/3 patient have diabetic retinopathy, and creatinine was in the tune of 7 mg per deciliter. So once we have biopsy, the breakup of histology was non-diabetic. After biopsy, even you can see diabetic kidney disease was seen in around 1/3 of patient. Non-diabetic kidney disease either on isolate basis or superimposed on diabetic nephropathy was the most common diagnosis, which was seen in around 85% of patients. Out of these patients, 78 patients, out of these 135 patients, 78 patients found to have glomerular disease, in which you can see diabetic kidney disease is most common cause of glomerular disease, secondary glomerular disease, while in primary glomerular disease, concentric glomerulonephritis was the most common cause, which is seen in around 12% patient, followed by membranous glomerulonephropathy. Other diagnoses in our case series is FSGS, MPGN, IgA nephropathy, and minimal change disease, and one patient found to have C1q nephropathy and lupus nephropathy. Coming to the breakup of concentric glomerulonephritis in our patient, 16 patients found to have concentric glomerulonephritis. Out of these, most common cause of concentric glomerulonephritis was post-infectious glomerulonephropathy, followed by ANCA-associated vasculitis. So when we reviewed the literature, we found that these patients of diabetes with crescentic glomerulonephritis have high incidence of post-infectious glomerulonephropathy, possibility related to high prevalence of skin and soft tissue infection, and this can contribute to progressive kidney disease. I also shown you the one case in which you have seen a diabetes with furunculosis and who has deteriorated renal dysfunction. So coming to the primary glomerular disease out of these patients, the most common primary glomerular disease in our case series was membranous nephropathy, which is consistent with the other data from the other part of world. 57 patients found to have tubular interstitial disease. Out of these, the most common is acute interstitial nephritis, either as isolated or superimposed on diabetic kidney disease. We also found to have 3.7% patient of cast nephropathy. In our patient, AIN was the most common histological lesion overall, among even on glomerular as well as on tubular disease. The high rate of acute interstitial nephritis in our study cohort may be because of enrollment of patients with atypical manifestation of renal disease for kidney biopsy, or because of higher frequency of infection in this population causing acute interstitial nephritis. So outcome in these patient who have isolated acute interstitial nephritis, dialysis dependency is less than patient who has acute interstitial nephritis superimposed on diabetic kidney disease. We also found to have 8 patients of multiple myeloma associated kidney disease. Here we found 5 patients of cast nephropathy, 2 patients of acute interstitial nephritis, and 1 patient of chronic interstitial nephropathy. When we reviewed the literature, we found that myeloma in a patient of diabetes is increasing in frequency with the odd ratio of more than 1, around in the tune of 1.22. So what may be the clinical predictor of non-diabetic kidney disease in a patient of diabetic? So there are 3 clinical predictors which are important in our study: is absence of retinopathy, presence of hematuria, and diabetes duration less than 5 years. Out of these, the most sensitive is diabetic duration less than 5 years, followed by absence of retinopathy and presence of hematuria. So whether there could be any predictor model to predict non-diabetic kidney disease in a patient of diabetes. So in a study which is published in 2008 in NDT, diabetes duration, systolic blood pressure, concentration of HbA1c, hematuria, and diabetic retinopathy were identified as 5 major differential indicators. So overall outcome at discharge in our patient who has non-diabetic kidney disease superimposed on diabetic kidney disease has worse renal outcome at the time of discharge, followed by pure diabetic kidney disease and non-diabetic kidney disease. So to conclude, all diabetic need not have diabetic nephropathy as cause of renal dysfunction. High index of suspicion needed for non-diabetic when we have clinical leads. We should be rational in selecting patient for biopsy, as even after suspicion of non-diabetic kidney disease, big chunk of patient may still have underlying diabetic nephropathy or diabetic kidney disease. There is no single predictor for non-diabetic kidney disease, but combination of these predictors may be beneficial. Infection in diabetics may used to predispose to poor renal outcome, and diabetic remains an adverse factor for renal survival, either as diabetic nephropathy or non-diabetic kidney disease. Early identification of non-diabetic kidney disease can delay the decline of renal function by taking early therapeutic decision. Thank you very much.